Welcome to the COPD Foundation podcast. We bring you insights from leading health professionals, inspiring stories from those living with lung conditions, practical advice, and the latest in lung health research. Be sure to subscribe, follow us on social media, and visit copdfoundation.org. Take action today, breathe better tomorrow. Just a quick note before we jump into our topic. This podcast series was created for educational purposes only and is not a substitute for formal medical advice. Talk to your healthcare provider if you have any questions.
Welcome to this episode of the COPD Foundation podcast. I'm Johnny Karenko, a respiratory therapist and educator at the COPD Foundation. We're joined by Mike Hess from our Advocacy team, who leads World Oxygen Day and is guest hosting a two-part series on oxygen therapy. In this episode, we're exploring how healthcare providers can better help their patients prepare for living with oxygen therapy. Over to you, Mike.
We know that everybody needs oxygen, but we also know that some bodies need a little bit more. Unfortunately, oxygen therapy users experience, as the American Thoracic Society put it in a report a few years back, frequent and varied problems with their oxygen equipment and therapy. My name is Mike Hess. I am a respiratory therapist by training, and I am Senior Director of Advocacy and Regulatory Affairs. And those issues in oxygen therapy are why I am very excited to have a couple of special guests, my respiratory therapy colleagues here on the COPD Foundation podcast to discuss what some of those barriers are and how we can work together to reduce them. So if you would both please introduce yourself.
Hi, Mike. Thanks for having us. My name is Chrysalis Ashton, and I am the Director of Clinical Operations for a durable medical equipment and home care company based in Michigan.
All right. My name is Krystal Craddock. I am a respiratory therapist at UC Davis Health, working in our outpatient clinics for asthma and COPD.
We'll just jump right into it. I'll start with you, Krystal, as somebody who is usually, as I understand it, a little bit more on the assessment prescribing side of things. What do you see as some of the major barriers to identifying who might be able to benefit from supplemental oxygen and then starting them on into that pipe?
Yeah, I think, where I'm located here in Sacramento, we cover a large rural region, patients all the way up to the Oregon border over through Ringgow. And so we have patients who will come into our office with normal saturations. They're pretty much at rest, walking from the waiting room into the exam room. And we might not identify at that point that they actually require supplemental oxygen, whether it be that they live at altitude and they have a hard time breathing up there, and they notice their dyspnea is more on exertion when they're up at that altitude. And as well, we have patients who, live in 2-story homes, 3-story condos, all of those things. And so we need to ask the appropriate questions when they're coming into clinic, recognizing that their oxygen level might be normal at that time, but asking them questions such as, what their dyspnea level is. Do they check their saturations at home? Do they notice that they drop lower when they're moving around, when they're walking? And then when we do a walk test with them to identify if they require oxygen while ambulating, it's important to ask them questions about their home, about how far they walk. Do they have stairs? And so I often, when I'm asking these questions of patients, I'll take them into our stairwell and we'll walk. Some of them outwalk me up the stairs and do great, but others we identify as requiring oxygen during that ambulation. So asking more questions focused on what they're doing, what their normal level of activity is, what they would like to do, what their goals are to do, and what's holding them back from that. And if it's oxygen that's something that's identified as being required, then we need to go that extra step in testing them and writing that script if it's necessary.
So then, Chrysalis, once you get a prescription to set somebody up on oxygen therapy, can you walk us, no pun intended, through the process of how that goes from the prescriber to the actual setup?
Sure, absolutely. So we get orders in a variety of ways at our company. Fax and then e-prescribing are very common. The challenges that we face on the provider side are that all doctors are a little different, and all of them write their prescriptions a little differently. And because insurances such as Medicare, Medicaid, commercial insurances, they have certain qualifications that we have to meet in order to be able to bill oxygen equipment to a patient's insurance. And we have to have certain I's dotted, T's crossed, certain diagnoses. We have to have very detailed notes. And that can be challenging. We do a lot of back and forth with our physician partners because they're not all that familiar with how to order oxygen right the first time. And so things like e-prescribing has helped, but we're still kind of in the early stages of that. And it's challenging. So we obviously oxygen is a very important need, and we consider those urgent orders. And when we get one, we want to get them set up that same day if possible. And that is our goal. But when we have to go back and forth with physicians, it can be up to a couple of weeks before we get everything that we need. And in that time, we either are setting up equipment that is not reimbursed, and that's at our expense, or the patient is going without for that time until we can get that documentation in place. So once we get what we need, the process goes pretty smoothly.
So then how, and this is a question for both of you, how do you think suppliers and prescribers can work together and build a relationship so to kind of smooth some of that out? What does each side need to know about the other to really make that work a little bit more effectively?
I think that's really important. We need to make friends with our DME companies and understand what exactly they need, have frequent meetings with them. That's what we do within our programs at UC Davis, is touching base with the coordinators for our facility and finding out what the new CMS updates are as well. Things change. And so we need to know what the providers need so that we can all work together to get what's necessary for our patients in a timely manner, as Krystal has mentioned.
Yes, I 100% agree with that. And things like having a very simplified template that we provide to our physician partners is helpful, or like I mentioned, e-prescribing, because all of that is built within the system so that you can't move to the next step of the ordering process until you have the documentation attached or the saturations listed. Those kind of things help a lot. And then, making friends with the DME partners, highly recommend that. I tell that to everyone I talk to, that your DME partners are your friends, and we want to help just as much as the physicians do.
So there are a lot of different kinds of oxygen devices on the market right now. How do you, and again, kind of describe what each of your roles may be in figuring out what the best kind of equipment is for a particular individual?
I think understanding the disease process and the trajectory of some of these disease processes is important, and speaking to patients about that openly and honestly. I've had experiences in the past with, certain patients where they start off with a POC, and long-term, that might not be the best option. And it is really difficult for some of them to give up that POC. They do not want to.
And I'm sorry, in this context, the POC is?
Portable oxygen concentrator. It can be difficult for them to give that up when they need to have more higher flows, continuous flows. I think, really having that honest conversation early on and identifying those patients is important, and talking to them about the different options that are out there. And of course, I was just talking about this before the podcast started. The AARC is going to the Hill next week to advocate for the Supplemental Oxygen Access Reform Act. And hopefully we can get liquid oxygen more available to patients who need it. There are a lot of them who do. And it's unfortunate, seeing patients who really require that and cannot get access to that in some areas of the country.
So, Krystal mentioned liquid oxygen. Can you tell us a little bit more about that and why that is so hard to come by these days?
Yes, there's quite a bit of backstory to this, but I will just leave it to the reimbursement for liquid oxygen has fallen so low that it is not sustainable for most providers, such as ours, to provide that to a large population of people. That type of oxygen is expensive to maintain because you have to have the liquid vessels, you have to have the proper filling trucks and licensing that goes along with that, the labor that goes along with that, because it's usually a weekly delivery and it can take quite a long time to fill, depending on how many vessels the patient has. And so, as unfortunate as this is, it really does come down to cost, because when Medicare, as an example, only pays a DME company a certain flat rate for any type of oxygen, it doesn't matter if it's liquid, if it's a stationary concentrator, if it's an oxygen tank or a portable oxygen concentrator, we get the same flat rate regardless. And so, we got to stay in business or we can't service any patients, and we have to go with the cheaper option in a lot of cases. There are some companies, the one I work for is an example, that still offer liquid, but in very specific extreme situations. And it is better for higher liter flow patients. So if there is a patient that, for example, is on hospice that needs that, and it's going to be a short-term need, we can provide it, but we just can't offer it to the general population due to costs.
So then if portable concentrators can't really oxygenate somebody very well because they need a higher flow and liquid isn't available, what are their options?
Great question. And I will preface this by saying that all DME companies are a little bit different, but typically each one will have the oxygen equipment that they lead with. And in our case, it's a stationary concentrator, which is the size of about a small suitcase, plugs into an outlet. It's kind of noisy, but it takes room air, concentrates down the oxygen in that room air, spits out the rest of the gases, and then provides the oxygen to the patient. And that is considered a home or stationary system. And then for a portable oxygen system, we lead with tanks. Tanks are heavy, tanks are bulky. They can be challenging to change out regulators if you don't have great dexterity in your hands. So not ideal for a lot of patients. It does work for some. And then right now, our process is that if the patient requests or if the physician requests, we will test the patient for a portable oxygen concentrator. And there are many, many limitations that go along with those, which is frustrating on our end, because patients see these commercials or they hear from a friend that there's these little devices that last all day and you can do whatever and go anywhere you want, when in reality they don't provide the same level of oxygen as the tank, for example. They may not provide continuous flow. They might only provide a pulse dose type of oxygen, which is inappropriate for some patients. And the batteries, they still need to have batteries. And the more battery life you have, the heavier the device. And so there is still challenges with portable oxygen concentrators. But as of right now, we lead with tanks, and then we offer POCs for those patients that it's appropriate for, or if their physician really wants them to try it. I will echo what Krystal said, though, that patients get really excited about these POCs sometimes, and then they come in and we test them, and it doesn't work, and they can't keep their saturations where they need to be. So we have to unfortunately say, tanks are the best option for you at this point.
So it sounds like both of you have some experience with some of these difficult conversations where somebody is expecting a certain reality with oxygen therapy, and then when push comes to shove, it turns out a little bit differently. Krystal, we'll go back to you for a second. In your clinic, how often does something like that happen, and how do you respond to that? How do you have that conversation about how oxygen therapy will impact somebody's life?
Yeah, early. When we see patients in the hospital and we're transitioning them, specifically our COPD population with an exacerbation, we'll talk about oxygen with them before they even maybe need it at home. But when it comes to having the initial discussion about, you need oxygen, we do get a lot of, I've seen this commercial, just like Chrysalis was saying, these small little things, and they don't look the same in person. They're heavy, as Chrysalis mentioned, and the battery life, it doesn't last all the time, and it doesn't meet everyone's needs. And so we have that discussion early on, and we talk about the DME provider that we will send the order to, and it depends on what devices they carry and what they have available and in stock. Some of them don't have portable oxygen concentrators. It will meet their needs. Sometimes they don't have them. And so we have that conversation pretty early on with our patients who are requiring oxygen, just to educate them a little more. It's just like with anything, when you see this latest and greatest thing and thinking it's going to be everything you want and need, it's not always the case. And so we try to, gently provide education on that, as well as that oxygen doesn't mean you're going to be stuck at home. We want patients to get out. We want them to live their best life, and have a good quality of life. And so we do try to get them, the oxygen they need to be able to move and get out and, do what they want. But that will also meet their needs.
A situation that we see somewhat often is, like I mentioned, if we're putting a patient on any type of portable system that conserves oxygen to make it last longer, we can put a conserving device on a tank, or a portable oxygen concentrator is considered a conserving device as well. So we always test the patient in our offices or in their homes. And sometimes we'll have a patient that hasn't been using their tanks because they can't manage them, or they don't understand, or they're too heavy. They get really excited about the possibility of a portable concentrator. We test them, and they're either very much on the border, or it's still not quite meeting their needs. But the alternative is they don't use oxygen at all, or they never leave their home. And so we've made some judgment calls before where, you may be maxed out on this thing. Just so you know, you might need to take it a little bit slower, take longer breaks, but we're going to provide it for you because we want you to use something, get your therapy somehow, and we don't want you to be stuck at home. So there is some challenging conversations to be had there as well, and some decisions that need to be made.
I imagine a lot of these conversations also include families and caregivers and so on. What is the role of a caregiver or a family member in supporting somebody who is on oxygen therapy?
I think, we hear in the adult setting, patient-centered care. And in the children's hospital setting, you hear more of family-centered care. I think that it should always be family-centered care. We need to have the discussion with the caregivers and family members and make them a part of this, as well as providing education to them. When we try to provide education to our COPD patients on their disease process, on their medications and everything, as much support as we can get involved in that education, it's really important. And the same when it comes to oxygen. It is ultimately the individual's decision, but the more education you provide on everything, on your recommendation, the more buy-in you get from the patient and the family member. And, the family member is their biggest supporter and advocate. So I think it's really important to bring them in, and have them a part of the discussion.
I would agree with that. And in DME companies, we are required to have an emergency contact on file. And we also try to make sure that we have even if it's a spouse, for example, as emergency contact, we try to see if there's daughters, sons, grandchildren, anybody else that we can talk with and bring into the education portion, and also come in with the family member if they're doing a conserving test, so that not just the patient knows how to use the equipment or understands the process, but there's multiple people. And that helps, obviously, the family and the patient. It also helps us support these patients to be more independent among themselves and with their family. So that can be beneficial both ways.
A few years back, when I was working in a primary care office, we did a community survey about various aspects of COPD. And one of the things that came up in the survey was that if somebody, and this was just a general public survey, but one of the things that came up was somebody who is using oxygen therapy is assumed to be near the end of their life. They're really kind of trailing off, and this is an advanced stage of disease, and so on and so forth. Do you see that in your communities? And are people with oxygen therapy equipment stigmatized or looked down upon in any way? And how does that impact their care?
I believe more so that patients feel they're going to be stigmatized. And I could be completely wrong, but I feel like they really think, oh my gosh, I'm going to have this hose on my nose. Everyone's going to see me. This is going to be a problem. I think you see that a lot early on in their oxygen, needs when we're just starting the order, and they're really hesitant about wearing it out in public and everything. And, they think about that stigma, and it bothers them more than I feel they really are being stigmatized. I think part of problem might be the healthcare community. I think, physicians need to be more aware about, these patients who may have gotten COPD from smoking. They know that they smoked and they caused COPD. There's other factors also that cause COPD. And so, by doing that, I think that's where it might all begin. And so we need to be more cognizant about how we are approaching people in providing education.
And I would say that there is a stigma. I mean, I don't know that we can really deny that. You see somebody with oxygen and you assume that they were a smoker or something when that's not always the case. And definitely most of our patients feel very uncomfortable with it. And it's challenging to get some of them, if not most of them, to use their oxygen outside of the home. We have patients that come in that we know are supposed to be on at least 2 liters all the time. And, I left it in the car, or I don't like wearing it when I'm out of the house or something like that. So I definitely hear and feel that. Where I've seen some better success, and I need to give a little bit of a back history on this. It used to be that respiratory therapists in the DME world delivered and educated and set up all oxygen equipment for every single patient. And this was like the glory days of the 80s and 90s. Unfortunately, again, because of insurance cuts and reimbursement decreases over the years and the decades, we can't do that anymore. We send a trained delivery driver, and a lot of our delivery drivers are wonderful people and very knowledgeable. But at the end of the day, they're not a respiratory therapist. And so if a patient is able to see a respiratory therapist, and we can't at this point see all of them, but we see a good portion, if we can sit down with them and explain a little bit more about what the oxygen is actually doing, and these symptoms that you're feeling might go away if you use your oxygen more consistently, and know you're not going to get addicted to it. and some of those questions that a delivery driver is not going to be able to comfortably answer, then we have more luck getting patients to understand and use it more. And then they come back and they're feeling better. And so I think having respiratory therapists and access to respiratory therapists really helps cut down on that stigma, because we can provide the understanding and the rationale behind it.
You've both mentioned reimbursement cuts and reimbursement reform, the Supplemental Oxygen Access Reform Act, a couple of times throughout the program now. So obviously that's a key part of legislative reform that we need to hopefully see advance through this Congress. What else can we in the advocacy community do to improve the oxygen therapy landscape?
Whenever possible, working with some of the manufacturers and partnering with some of those companies, because although oxygen therapy has there's been improvements, you can't doubt that from again like 80s 90s time, but there's just not enough. There's not enough innovation. There's not enough forward moving projects or anything like that out there, because it, as unfortunately, is not a moneymaker, at least not currently, and it's challenging. We in the DME space would absolutely love to see smaller, lighter, longer lasting devices that we can provide to patients. Obviously, cost is an issue, so something that's relatively inexpensive for the value that it provides. And so any partnerships there, I think, would be very helpful. And then with physicians, with help us educate our physicians to understand when, how to order oxygen would make that process go a lot smoother. And I think it would get more people on oxygen sooner if there was a better understanding of what the whys and the hows.
I think being good stewards of oxygen is important as well. Not every person that goes on oxygen, especially from the hospital setting to the outpatient setting, requires the continuation of oxygen. Sometimes it's just short term. And so reassessing patients at a certain interval is really necessary. And of course, we've all seen this in our work on the clinical practice guideline and for our home oxygen, is that about a little over 40% of patients actually still don't require oxygen after they leave the hospital. And so if we're testing those patients and then, talking to them about discontinuing the oxygen and having the DME, company coming and picking it up and not continuing that, bill and payment and everything that's frankly unnecessary. We talk about management of chronic diseases. You're going to escalate and de-escalate, and we're going to have to do this for our oxygen patients. And I really believe that this could help with cost savings in the long run.
What's a potential bright spot you see on the horizon for oxygen therapy? A lot of what we've covered today is a little bit on the downer side, but what do you see as some positives that those folks in the oxygen community can look forward to?
I'm really excited about the SOAR Act. I know we've mentioned that a few times. This is a project near and dear to my heart as a provider, and as someone that works with oxygen users every day. And also, I mentioned earlier that there needs to be more innovation, but there are a handful of companies out there that are pushing forward anyway, and there are some cool products on the horizon that I'm excited about. There are people out there who care and who want to make patients' lives better, whether they are respiratory therapists or they are manufacturers or just someone with a very kind heart or had a family member that had oxygen therapy. And so those things brighten my day and make me hopeful for the future that we can make this a better landscape for oxygen users across the globe.
I 100% agree with Chrysalis. I'm really excited about the SOAR Act. And anyone out there who can write a letter to your congressman, your congressperson about the SOAR Act and supporting it, making sure that we get patients access to respiratory therapists, as Chrysalis mentioned, so that they can provide that education, the setup, the reassessment that these patients need. And also, hopefully, fingers crossed, more access to liquid oxygen.
Thank you, both of you, Chrysalis Ashton and Krystal Craddock. Both of you very much for your work in the community, for taking the time to help us learn a little bit more about oxygen therapy, and for your optimism about the SOAR Act and getting people the tools that they need.
Thank you for joining us today on the COPD Foundation podcast. We hope that this discussion has shed some light on the crucial role that providers play in adequately providing and preparing people living with COPD for oxygen therapy. Special thanks to Chrysalis Ashton and Krystal Craddock for sharing your expertise and your unique perspectives. For more information about World Oxygen Day, visit the COPD Foundation website at www.worldoxygenday.org. Thank you for tuning in. Be on the lookout for more episodes where we delve into all things respiratory. Take action today, breathe better tomorrow.
Thank you for tuning into the COPD Foundation podcast. And remember, whether you're managing a chronic lung condition, providing support to those who are, or just want to learn more about lung health, the COPD Foundation is here to support you. Be sure to subscribe to this podcast and follow us on social media. Take action today, breathe better tomorrow.